Good morning and welcome to the San Francisco Interfaith Council online briefing for faith leaders. Today's program will address mental health challenges, overdose, and care for San Franciscans. A special thanks. The San Francisco Interfaith Council online briefings are supported by a grant from MetaFund. Thank you. The important and ongoing work of the San Francisco Interfaith Council would not be possible without generous funding from congregations, corporations, faith-based social service agencies, foundations, judicatories, and supporters like you. Help us spread the word. Visit sfinterfaithcouncil.org to learn about SFIC programming and how to become a supporter. Follow SFIC on Facebook, Twitter, and subscribe to SFIC's YouTube channel to watch all of our previous virtual events. A bit of housekeeping. Today's program is being recorded. For audio and video, all participants are muted and without video to minimize distraction. To submit a question or comment, select the chat button at the bottom of your screen and send a message to Q&A. Questions will be forwarded to the presenter for their review following the program. To activate closed captions, select the live transcript button at the bottom of your screen and click Enable Live Transcription. San Francisco and surrounding counties are requiring masking in indoor public places for everyone as a precaution against the increased circulation of COVID-19. This includes settings like houses of worship, grocery and retail stores, theaters, and family entertainment centers. For updates, watch for SFIC emails as the health orders evolve. Anyone 12 and older will need to show proof of vaccination to go indoors in some places in San Francisco, like restaurants and bars, gyms and clubs, large indoor events, and any business or event serving food or drinks indoors. To find your vaccination record, go to myvaccinerecord.cdph.ca.gov. Get vaccinated, San Francisco. The vaccines are safe and effective. Go to sf.gov/get vaccinated to find a vaccine site in your neighborhood. Now is the time to come together, San Francisco. Together, we can stop Asian discrimination, bias, hate, and violence. The COVID-19 virus has no race or nationality. It is simply a disease. To report a hate crime, call the SFPD at 415-553-1133. And at this time, I'd like to hand the floor over to the Executive Director of the Interfaith Council, Michael Pappas. Michael, the floor is yours.
Thank you, Trey, and good morning. I'm Michael Pappas, and on behalf of the San Francisco Interfaith Council, I want to welcome you to this week's online briefing for faith leaders. If anything, COVID-19 has amplified and drawn attention to numerous needs and inequities in our city, not the least of which are mental health challenges and related care for San Franciscans. In San Francisco alone, over 700 people died of drug overdose in just the past year. This week's online briefing for faith leaders, hosted by the San Francisco Interfaith Council, welcomes Dr. Hillary Kunins, Director of Behavioral Health Services and Mental Health SF for the City and County of San Francisco, who will share the Department of Public Health's new initiatives and priorities to improve access to care and substance use treatment, reduce overdose deaths, and reach people experiencing homelessness. As faith leaders are considered partners in our city's mental health support system, Dr. Kunins looks forward to this opportunity to connect our city's faith communities to care and hear from faith leaders about what is working and what is not. At this time, it gives me great pleasure to introduce our council's founder and past chair, Rita Semmel.
Good morning, everyone, and welcome. This is an interfaith community. Whatever our individual belief, it can be freely expressed here with no apologies. If we are invited to offer a prayer in this setting, it should be offered according to the tradition with which we identify. If we are invited to speak on a subject, from the perspective of our tradition, we are free to do so without fear of offending those who come from another tradition. We come together as people of faith to learn from each other that we might better understand the multiplicity of faith traditions in our city and in our world. Welcome and good morning.
Thank you, Rita, and thank you for all that you do. And we know that you have a Human Services Agency Commission meeting upon which you sit as a commissioner. And please extend our greetings to the commission and appreciation for all of the good causes they support in the city.
Thank you.
We are very fortunate to have with us this morning to ground us in a reflective moment, Reverend Dr. Jonathan Butler. Reverend Butler is an associate minister at Third Baptist Church, a research faculty member at UCSF Department of Family and Community Medicine, and also the executive director of the San Francisco African American Faith-Based Coalition. He also serves on the board of the San Francisco Interfaith Council. We are very grateful for that. Reverend Butler, we also wanted to extend to you and to the African American community our condolences on the passing of Reverend Calvin Jones, longtime pastor of Providence Baptist Church. He was a close personal friend and a friend of our councils, and we are sending prayers to the community. Would you please ground us in a moment?
Thank you, Director Pappas, and to everyone who's joined us this morning. Good morning to you. And of the many hats that I tend to wear, this morning, I wanted to put on my research hat and to help us to prepare for the talk that is after me. And many of you may not know that my research actually focuses on the relationship between religion and health. And so I wanted to talk to you about what we know in terms of the research regarding religion and mental illness. There are positive uses of religion, as we know. Many people turn to religion for comfort when stressed. Religion is used to cope with common problems in life that we often face, especially involving the loss of a loved one. Religion often is used to cope with challenges associated with medical illnesses, uncertainty, fear, pain, loss of control. There's a plethora of studies out there actually that demonstrates that religion is associated with less depression and faster recovery from depression. Religious involvement, such as attending church, is related to less anxiety. In some instances, it's also related to more anxiety. There's many studies that show that religious involvement is related to less alcohol use, especially among the young people. Religious involvement is related to less drug use, especially among the young people as well. Religious involvement is related to more forgiveness, more altruism, and more gratitude. And so there are many studies that have proven that religion is associated with better mental illnesses. As a matter of fact, my mentor, Dr. Harold Koenig, is actually a psychiatrist at Duke University. He studies this intensely and has studied religion and mental health. And he shares with us, his students often, is that there's no need to study religion and mental health anymore. We have enough studies that show that there is an association with just simply attending a church once a week that has better advantages for someone who has depression or anxiety. But there are also some negative effects on mental illness, mental health, and social functioning. For example, as we observe this month is Breast Cancer Awareness Month, many men and women who have the experiences of breast cancer may sometimes feel that it is God that has given them this ailment. So there are some negative impacts on mental health. And as many of you know, also in regarding to caregiving, as one experiences a loved one who has to suffer or who has dementia, for example, there is some element that many people feel that, God is responsible for this. So there can be some positive effects and negative effects as it regards to religion and mental health. But I want to leave with this point is just because we've gotten bad news doesn't mean that the worst is imminent. That's the first thing. And we shouldn't lose faith, even when we have to grapple with the fact that we may experience depression, not only with ourselves, anxiety with ourselves, with our family members, but don't lose faith. And I also wanted to make mention that of the power of the word of our testimony, and that sharing stories about our experiences that we feel, that our experiences that we face, even in our families, goes a long way. And that we shouldn't use mental health as a stigma, but to share what we all experience, that we all need some aspect of mental wellness, as I like to put it. And then lastly, that we can all live, that our faith emphasizes and enables us to live throughout the challenges. And there's a book that I often reference. It's called The Obstacle is the Way. We always face these challenges, whether it be mental or physical. But as we are talking about a mental health, this is a challenge that our families face, our communities, our churches face. This past week, 2 of our young people committed suicide. And so I want to encourage everyone to know that, everyone experiences some sort of a mental illness throughout their lives, or they may experience it, but always keep the faith. Don't lose faith, and know that there's power in the word of our testimony and that we can live. And that's what I wanted to end on. And just to put a note that in studies, religion is oftentimes associated with hope. And so I wanted to encourage everyone to stay grounded in your faith, because there are not only physical benefits of that, but there are also mental benefits from a scientific perspective. Thank you for allowing me to share, and looking forward to our presentation today.
Thank you so much, Reverend Butler. And it's a perfect segue to introducing our presenter today. Dr. Kunins speaks to a lot of different groups. Today, she is speaking to people of faith, and in particular, faith leaders. And as I mentioned to her in the waiting room, that this recording link will be sent out to our 5,000 e-subscribers. This is a unique audience. We are here to learn from Dr. Kunins today, as well as to try to figure out how we can be of better support. We are so grateful for your presence with us, Dr. Kunins. And you've started at a very unique time in the history of San Francisco. Your distinguished career is noted in the program announcement for today. You come to us from New York City with a whole resume of experience, and I suspect that will be very helpful to you in terms of acclimating to our city and to doing the work that you've been called to do. I did want to tell you that our council got its start over 30 years ago with an emerging homeless crisis in San Francisco, which really was the aftermath of a lot of the Reagan administration policies. And we have been hosting an interfaith winter shelter for over 30 years. And so a lot of the issues that you're dealing with are issues that we're dealing with, and our congregations are dealing with on a day-to-day basis as they're on the front lines. We welcome you, and we look forward to learning from you.
Well, thanks so much. It's a great pleasure to be here. Really, many thanks for inviting me to speak with all of you and to learn with all of you. As you just noted, I am still pretty new to San Francisco. I'm now in my 7th month in the city. I am a long time, nearly lifelong New Yorker. And I think your description is, the words you use to be called to this work has been my career trajectory. Just by way of background, I'm an internal medicine physician. I trained in primary care, worked for many years clinically in the Bronx, and specifically the South Bronx, which is an area of New York City that has been hard hit by poor and frankly racist social and other policies. and the people I took care of frequently experienced a whole range of behavioral health challenges, whether serious mental illness, less severe but difficult to manage anxiety, depression, risky substance use, and over the most recent part of my career, the Bronx and like parts of San Francisco face disproportionate overdose deaths. So it's very exciting to be here in a city that is really ramped up, I think, both resources and resolve to address some of, I think, the thorniest and disconcerting challenges of our day. And with that, I have a presentation that I wanted to share with all of you that describes some of the things that we are doing at the Department of Public Health to work towards improvements in these areas of serious mental illness and substance use disorder or addiction. And at the end, I will sort of circle back to what I think is really for all of you who may have congregations or working with folks more broadly who not only a minority of whom likely experience sort of the more serious end of the spectrum of challenges, but as Dr. Butler, you so eloquently described, really all of you may well be in the position of supporting people with a whole range of symptoms or experiences, and you are in a great position to promote mental health and well-being in our city. Next slide. So here's what I'll focus on today. I'll speak about what we are doing now that's new around mental health SF and overdose. I want to specifically speak about children and youth and mental health, and also about our work centering and advancing racial equity, and end with just briefly what I think faith leaders can do. And I'm sure you have many of your own thoughts, and we will have time for some questions and answers. Next slide. So, so on this slide, you can see our goals, priorities, and the guiding principles that inform the work of the Division of Behavioral Health at San Francisco's Department of Public Health. We aim to increase the quality of life and reduce mortality among all people with serious mental illness and/or substance use issues. We aim to improve access to and quality of the care that people are receiving. Our priorities right now are to reach and treat people experiencing homelessness who have a mental health or substance use challenge. We are aiming to reduce the epidemic of overdose deaths. And to do that, we are seeking to strengthen the behavioral health workforce in order to be able to deliver the life-saving care that is needed. The principles that underline our work is that achieving racial equity and outcomes is paramount, that we have to fill gaps in a variety of levels of care in San Francisco, and that part of that work must be to build up what I will call proactive and low threshold services in order to pull additional people into the care continuum. Next slide. I hope this will lay out a way to think about the behavioral health care safety net. And for those of you who may have friends or family in need of care or seeking care, a lot of what we do in specialty care may not be obvious to you. And I know that we are also often victim to using a lot of jargon and a lot of technical words. So this upside down pyramid is our attempt to describe levels of care, ranging from prevention, early intervention, and outreach to reach a larger number of people who may be experiencing lower intensity of symptoms or illness, or none at all, and just prevention work. The next is street and community-based work, where really we are attempting to do outreach and engagement. May not include formal treatment, but really is a way to pull people into care who might need it. Most people can who need treatment, the majority of whom are appropriate for outpatient treatment, meaning similar to seeing a therapist or a psychiatrist in an ambulatory care setting similar to a primary care setting. More intensive services you can see now in blue and purple, residential care for people either whose illness is severe enough or they are experiencing homelessness and cannot attend to treatment without housing. We offer crisis programs and psychiatric emergency programs, and our most intensive levels of care are hospitalization, including involuntary treatment using a variety of laws that are available in California and San Francisco. And for some of those folks, because of the severity of their illness or risk to other people, care and treatment in a locked facility becomes the most appropriate course of action. I also want to call out on the right side of the slide the relationship that we have and need to have with housing. As we say now increasingly in public health and in healthcare, housing is a health intervention. And so we have a range of housing or residential care options, including permanent supportive housing, which you've been reading about as big interventions being rolled out by the state and the city to increase access to housing. But no doubt inaffordability or affordability is a crisis here, not only in San Francisco and the Bay Area, but really nationally and in many, many higher cost cities across the country. Next slide. So in terms of the services that we either directly deliver or contract for, the Department of Public Health in this fiscal year to date, we have treated approximately 20,000 people for mental illness or substance use disorder and provided prevention and early intervention services to more than 20,000 people in a variety of ways. And you can see those there on the slide. Next slide. What I'd like to focus on now is mental health SF. And as many of you likely know, mental health SF resulted from a piece of legislation passed by the San Francisco Board of Supervisors in 2019, with the overarching goal of increasing access to care for San Franciscans with serious mental illness and or substance use disorders and who are experiencing homelessness. Next slide. So I'd like to describe for you now what the key domains and programmatic areas are of mental health SF and share with you our progress to date. As you can imagine, although the legislation was passed in 2019, much of the funding arrived later in 2020 and now in 2021, part of which was under Prop C, a voters-backed initiative in San Francisco, funding both housing, which is outside of the Department of Public Health, as well as behavioral health services for people experiencing homelessness. So in mental health SF, the legislation outlines these 4 key priority areas: Office of Coordinated Care, Mental Health Service Center, new beds and facility, and our street crisis response team. I'll just describe each of these domains and then go on to share our progress so far. The Office of Coordinated Care aims to improve and centralize care coordination for clients so people don't fall out of care, so they are assertively retained in care so they can have improved health outcomes. The Mental Health Service Center is building off our what is called our Behavioral Health Access Center, where people can access care by referrals or walk-in basis as expeditiously as possible. We know in San Francisco and in California, there is a shortage of residential care and treatment, and this area of mental health SF aims to expand access to residential treatment. And then finally, our street crisis response team is a street-based response to people experiencing behavioral health crises on our streets. Next slide. So let me just share a little more specifics about where we're at, which in 3 of these 4 areas. The Office of Coordinated Care is very much getting built out right now. It will have the different components you see in the table in front of you, including a central coordinating team of care managers, a more intensive CCTM, care coordination transitions management team. You notice we're working on our verbiage there. We're going to have catchier names for more intensive care management to keep people glued to care. I mentioned our Mental Health Access Center, and we've subsumed that area of mental health SF into 2 parts: our Behavioral Health Access Line, which is growing by updating technology, increasing the number of operators, as well as our Behavioral Health Access Center, which is expanding its hours, as well as moving sites to accommodate more clients. We will be building out member services, that is people who are eligible for our services, to do awareness raising and essentially social marketing. And we will have components around eligibility. This is because these services are funded in large part with Medi-Cal dollars. And we are building out a transportation program to help people get into care. Next slide. Our street crisis response team, which has gotten really a tremendous amount of positive media coverage, is really unique, as far as I know, in the country in terms of a proactive, multidisciplinary, non-police response that is now 24/7 and reaches all areas of the city. The team provides rapid trauma-informed responses to calls, to 911 calls about people experiencing a behavioral health crisis. Our goal is to reduce law enforcement interventions and unneeded emergency department use. And we are undertaking an evaluation of that now. The team, as I mentioned, is multidisciplinary and includes a community paramedic. This is a specially trained EMT worker that is able to assess for medical needs, physical health needs, a behavioral health clinician to support the client's mental health or substance use needs, a peer specialist who has lived experience, who is expert in making connections and relationships with people. After the response call, we have the capacity now to follow up with clients out of our Office of Coordinated Care and to continue to connect, engage, motivate, and arrange other needed services like behavioral health treatment and housing. Next slide. I want to share this kind of dense slide, and it's likely, I'm guessing the audience members will not be able to read all those words, but I do want to share it with you. This is our dashboard showing our new beds and facilities work. We have this posted on our website and are updating this monthly. So what you can see, for example, in the first 4 kinds of facilities, we have made progress so that they are now open. And you can see where we are with the rest of the programming on the numbers and the carefully written code up at the top right corner. So what I'd like you all to take home from this picture is we are opening a great number of slots for people requiring more intensive levels of care or treatment, ranging from what we call low threshold respite programs, drop-in programs such as Hummingbird Valencia, which is the very first program that you can see with space for 30 overnight guests. On the other end, as I described earlier in the pyramid, you can see more intensive and restrictive services are also being expanded. Mental health rehabilitation beds, also known as locked subacute treatment, our new beds are now online and accepting patients. In total, this represents more than 400 new beds, adding to the approximately 2,000 that San Francisco already has. So this is quite a large expansion. Next slide. I want to now turn to the specific problem of overdose. And this is really a crisis right now in San Francisco. Further, the crisis is disproportionately affecting Black African Americans in San Francisco. So it is both, it is urgent and it is a matter of racial equity. Based on my own experience, my work in New York City and the work that's happening across the country, these deaths are preventable, and saving lives and our work around saving lives builds upon an already existing backbone here in San Francisco of services. And we are aiming to add equity-driven and, as I'll say, stigma-busting and proactive approaches to reducing overdose deaths in San Francisco. Next slide. So this graph illustrates our overdose death curve in San Francisco. So what you can see here along the x-axis, along the bottom of your slide, is the years, and on the right, left side of the slide, the number of deaths. San Francisco saw a rapid increase in numbers of deaths starting in late 2018 and continuing to rise dramatically through 2020. It appears that 2021 data, which is obviously not complete, there has been some leveling off of that curve, but still unacceptably high. And as I like to remind all of us, that every life lost is precious, and we can do much more to prevent those losses. In San Francisco, the overdose deaths are being driven by the entry of a potent opioid called fentanyl into the drug market. Fentanyl, some of you may recognize as being a pain medicine used typically in hospital settings, and it is a very effective medicine to relieve pain. Unfortunately, it is also, when used illicitly, poses very high risk of overdose because just a very small amount can suppress a person's urge to breathe, and that is what causes the overdose. Deaths, as I mentioned, in San Francisco are 4 times higher among Black African Americans, and are also occurring disproportionately among people experiencing homelessness. Other parts of the country saw fentanyl entering their drug markets earlier. For example, when I was in New York City, we saw a 50% increase in overdose deaths between 2016 and 2017. So what has happened here additionally is of course, this is coincidental with the COVID pandemic, where stay at home or shelter in place orders likely paradoxically increase risk of overdose, as more people may have been using by themselves, which of course increases risk of overdose because there's no one around to save them. And because of the experiences of social isolation may have increased drug use, which is sort of the story that's coming out nationally. Next slide. So I wanted to share with you our framework for addressing the overdose crisis, some of which is being implemented and expanded under the proxy initiatives that I mentioned before. We are aiming to do the sort of work in the following 4 areas: expanding overdose education and distribution of harm reduction supplies, including naloxone, which is, as you may know, an emergency medication that reverses the effect of an opioid overdose without any negative effects on people who don't have opioids in their body. Lay people can learn to recognize an overdose and respond using naloxone and calling 911. And we are encouraging lay people who might have friends or family who are at risk for overdose to consider learning about and carrying naloxone. We are expanding the use of something called fentanyl test strips, distributing these through our syringe exchange programs, through our behavioral health pharmacy. These are strips that people can use to test their drugs to see if there is fentanyl in them, and to take precautions by using less, choosing not to use at all, using with somebody else. We are also working to expand access to and remove barriers to high impact treatment. Treatment for opioid addiction is widely available in San Francisco, and the most effective treatment includes the use of one of two medications, buprenorphine or methadone. We are really pushing to make, in particular, buprenorphine more widely available through telemedicine, through what we call low threshold settings, either street-based or, as you'll see in a moment, in our street outreach teams. We are also expanding use of another effective strategy called contingency management, in which people are given incentives for positive behaviors. For example, showing up at an appointment. This strategy has been shown in scientific trials to improve people's retention and care, reduce their use of drugs, and keep them safe from overdose. We are also very much focused on people experiencing non-fatal overdose. And the reason for that is because they are at elevated risk for future overdose, including fatal overdose. And I'll return to this momentarily. And lastly, I want to really highlight this last bucket because I think this is really so important for faith leaders and all kinds of community groups, not specifically organized around substance use. We are aiming to increase social support and decrease stigma for people at risk of overdose and their loved ones. We know because of stigma, because of shame, lots of families and people can keep their drug use hidden. And it is by being hidden that it is harder for them to seek help, to feel loved, and to feel appreciated, and to feel that their life is valued. We are really looking for all kinds of ways, and I will highlight the bottom bullet around doing community education and organizing to reach both people at risk of overdose and their friends and family and loved ones. We know from all kinds of studies that risk of overdose not only is the substance itself, and I've highlighted fentanyl, but really all of the social, what we call social determinants of health, including experiences of racism, social isolation, economic instability, experiences of trauma in both in childhood and in adulthood. Additionally, we have some specific programs, and those are the first three bullets that you see in that right box. Soma Rise is a space that's opening in the winter. That is a recommendation that came out of the city's methamphetamine task force that will offer a safe space for people intoxicated with methamphetamine or other substances, and will ideally connect these folks to ongoing care. I mentioned Hummingbird Valencia, and I'll also just mention the city's work in advocating for safer consumption spaces. These are spaces that offer hygienic and wraparound services to people who bring their drugs and use them under supervision in order to prevent overdose, and again, to offer them linkage to ongoing care and services. Next slide. I'll just now highlight our SORT team. This is our street overdose response team. And again, this is a very specific tailored response to people who have experienced a non-fatal overdose. We launched just recently in August. We're now operating 12 hours a day, 7 days a week. The EMS community paramedicine team responds immediately to overdose calls, and then the outreach follow-up team seeks people out within 72 hours to connect them to care, services, and treatment. We're aiming to offer them life-saving interventions such as naloxone, buprenorphine treatment, or buprenorphine initiation, counseling, referrals that could be life-saving as well, like harm reduction, formal substance use treatment, importantly, housing and or shelter. Next slide. Oops, I think that's a double, so we can go on to the next slide. And I realize I'm going on a bit longer than expected, so I'm going to speed up. I want to really focus on children, youth, and families. This is an important part of our work. I think, as all of us will agree, it's important to intervene earlier to prevent problems and not just catch them when they are most severe. Our Children, Youth, and Families section of the Behavioral Health Program at DPH conducts prevention and early intervention care for the whole family. We interact frequently with other system partners that you can see there, and our services are developmental across the age spectrum. Next slide. We know that the impact of COVID on kids has been large, similar to for the rest of us. We've seen an increase in acuity or seriousness of mental health or behavioral health problems, and it increases in use of crisis and more intensive services. We have seen also that part of that picture, and I'll just highlight the bottom bullet, is that because of disruptions in caregiving or losses in people's family, kids are really experiencing this sort of secondary trauma from the pandemic, in addition to social isolation. And we are seeing a disproportionate impact, unsurprisingly, among families, including Black African-American families, where there's been disproportionate loss of life due to COVID. Next slide. Let me just highlight one opportunity that we have had during the pandemic to expand needed services, and that is our mobile response team. Initially, pre-pandemic, we had much more limited resources, but because of new funding, our Seneca 24/7 mobile response team has been able to respond to youth with severe behavioral health concerns, and we have been able to expand our ability to respond to all kids that are involved with city services, and increasingly working with San Francisco School District to be able to provide support to schools as well. Next slide. Well, I want to mention how important the behavioral health services workforce is to our success in expanding services and meeting the needs of San Franciscans. We have a number of programs, and for the sake of time, I'm not going to fully talk through this slide, both providing internship experiences, vocational services for people who may have a mental illness, and we are reaching at all levels of the educational spectrum, starting in high school, to try to recruit people into this really important and satisfying work. Next slide. What also, as I mentioned up front, underpins our work is both measuring equity in outcomes and reducing inequities in outcomes. And part of that is really looking at our services and to redesign them so they are culturally congruent. I wanted to mention this brand new program that will start in the coming months that specifically designed for Black African-American residents in San Francisco. And you can see here some of the strategies the program will be employing. Our goal is to better link consumers with someone who is representative of their intersecting identities. We know that people, when interacting with professionals, have better health outcomes when the person providing care has an identity that's congruent with their own. We are also implementing culturally congruent services such as African-centered storytelling, expressive arts, community rituals, and/or spirituality practices, really based on the interests and preferences of the participants. And we are aiming to hold trauma-informed community healing circles outside of the four walls of our specialty behavioral health system, such as at community programs, churches, faith-based programs, as well as other community settings. Next slide. So I'm going to just end here, and I'm guessing you all will have other thoughts and are more experienced as obviously as a faith leader than I am. But here are three things that I think faith leaders can help do. They can help normalize discussions of mental health and substance use disorders. And Dr. Butler already mentioned this, how important this is to tell stories, share experiences, provide models for people coping with and in recovery from mental health and substance use disorders. This works to help decrease stigma and to invite more people to seek help, share when they are suffering or when they need more help. And then finally, know where to get help. Doesn't mean, obviously, you need to be an expert, but to be able to get help or advice, and myself and my staff really stand ready to assist you with that. Next slide. And these two slides, and I know the PowerPoint will be sent out. This is a set of resources that I'm aware of that can help faith leaders get a bit more information, know how to talk about mental illness and substance use, as well as get some additional help. And the first slide is a more general one and mainly adult facing. And the second one is really focused around kids and youth. So that is all I have. I know I went on for a bit longer than expected, so thanks for your forbearance.
Dr. Kunins, this was a very comprehensive, a very informative presentation. And over the course of the week, we had reached out to a lot of our faith leaders anticipating your presentation and asked for questions. A lot of them you touched on, but we're going to ask you to pick up and amplify some of them. I guess the elephant in the room and why we started this programming in the first place was the impact of the pandemic. Now, I'm guessing that the pandemic has probably amplified issues that were already out there, but the issue of isolation in particular, domestic violence, people living in close quarters, how has the pandemic impacted your work?
Well, I think I want to name some of the negative effects, but also some of the potentially change the way we deliver services in some really important ways. I think for all of us, I mean, myself included, the loss of physical contact and being out and around in the world is really profound. And for folks who were able to get sufficient social support or connections, and I think you name domestic violence, importantly, we have seen from national studies increases in emotional and physical abuse. We have seen increases in prevalence of depression and anxiety. And I think that the jury is still out on Princ's suicide, honestly. So there have been some conflicting results. We have also seen, as I mentioned, increases in substance use, alcohol consumption in particular, as well as overdose deaths. So these are very real and sad consequences of the pandemic. Some of the things, and this is really drawing both from my work in New York and here, I spent most of the first year of the pandemic in New York, where I was deployed, like many public health officials, to work on all kinds of things related to the pandemic, including vaccination, including nursing home procedures, including early on implementing testing. And so what I observed in the behavioral health world is that the behavioral health provider community adapted, changed routines, moving so many services to virtual services. And I've got to say, and I was probably one of them, where the personal and in-person connection felt like a key part of the therapeutic relationship. And I think many of us were not confident that switching to virtual care would be successful. And I think that that has not borne out to be true, is that we have been, as a field, adaptive and have done things, and regulations have changed more quickly than we could ever imagine in government to allow for the delivery of virtual services, whether by phone, by video. And I think that is really an exciting and important development for a field in which there is a profound workforce shortage. And I hope will be something that stays with us as an option for people who prefer getting care that way.
Thank you. You mentioned the impact of the virtual. It's been a double-edged sword for our sector because thankfully the city has been so generous in getting us timely and credible information, which has allowed our congregations in particular to pivot very quickly to online worship and virtual ministry. But those congregations in the city that don't have the resources have not benefited. So it's been an equity issue. And that prompted a whole conversation on mental health. As you might know, the Institute on Aging here in San Francisco has something called the Friendship Line. And in the course of the pandemic, the state actually gave them a contract to work throughout the state on that. And one of the things I would just posit with you is perhaps stay in touch with Dr. Butler, because I think that there's a great need in the African-American community, not only for a friendship line, but also folks on the other end of the line who can answer that call as you and resonate with the voice that is picking up the line. And I just would say that as a thought and perhaps as a benefit of your participation in this program.
Absolutely. And I want to echo that, is that that we, and I'll speak to my experience in New York City more than directly here, but we know that as services switch to virtual care, a major preoccupation is getting the right technology out to our clients. And it is very clear that the people who are most disenfranchised are likely to have the least access to the technology needed. And so there have been a variety of there's work that in which cell phones are provided or hotspots are provided in order to promote access. It is by no means perfect, but I think it highlights the extent to which the technology must not be allowed to drive different health outcomes.
I was very grateful to hear you touch upon consumption sites. And let me tell you why. Early on, well, I would say during the Great Recession, our council began to convene the CEOs of the 15, 16 most prominent faith-based social service agencies in San Francisco. And at one point, I remember us seated around a table at St. Anthony Foundation, and a lot of our CEOs were being invited up to Vancouver because it was almost like a pilgrimage site. And they would come back and share their stories. And these CEOs are really on the front lines, and they're seeing their clients and how they're impacted. And they saw the benefit of these safe consumption sites and really sought and became advocates back then. I'm sure we've kind of evolved in the thoughts of that. I'm wondering for the benefit of those CEOs in particular, can you just share the opinion of your program and your office's thoughts on safe consumption sites?
Absolutely. So I think, I just want to acknowledge that for folks who are outside of the field that I have been working in for the last many decades, it can feel really startling to hear about. This is a space where you're essentially saying, creating a space where people can use illicit drugs. These are, again, spaces where people bring their substances. They're not provided with them in the space. There are more than 100 sites around the world, and many, if not most countries in Western Europe, as well as you just mentioned, Michael, in Vancouver, as well as in other provinces now in Canada. So and what we know about the science behind this has been a strategy that's been well evaluated, particularly in the Vancouver setting, and shows that it decreases public drug use in the area in which the site is located. It decreases overdose deaths in the neighborhood in which the site is located. It increases people's entry into treatment compared to people not using the site, and does not increase crime in the neighboring area. I think, so for those scientific reasons, our department supports adoption of safer consumption sites as one of multiple strategies to reduce overdose deaths, as well as to reduce public drug use. This is a hot topic nationally right now. The multiple cities are either poised or hoping to open these, including our neighbors in Seattle, Philadelphia, Massachusetts, New York City, and this was something I was also involved with in New York City. There are some legal concerns, and that is where the hesitation that has been going on recently based on the Philadelphia lawsuit, which some of you may be aware of, is worry or concern about whether the federal government would intercede with opening or with enforcing.
I'm watching the clock and I want to be ever so respectful of your time and also being respectful of our constituencies. In a different iteration in life, as a young clergyman in Chicago, where English was not the first language of most of the congregations there, the local Lutheran hospital, in their wisdom, offered a continuing ed program for clergy on personality disorders. And I still have the binder. It was a 12-week program where we were introduced to symptoms of personality disorders and were given healthcare professionals to make referrals. That was their way of engaging with the local clergy, realizing that the clergy didn't have the expertise or the capacity to do treatment. I'm wondering, you come from New York City. I'm guessing you probably worked with clergy there. How do you see partnering with the faith community to be supportive of the work of the city in terms of addressing mental health issues?
Well, we and I did a lot of work with clergy in New York City, and I think there are so many opportunities to work together, and I would really welcome your thoughts and ideas as well. I think hosting briefings so you all feel up to date with what's going on in the behavioral health sector in the city is one way. We would be very happy to do additional trainings or talks, not only from me, but from members, hopefully a diversity of voices on my staff with different kinds of expertises. There are fantastic trainings, including something called, which you may be familiar with already, mental health first aid, which is a great training program from the National Council on Behavioral Health, which is a great way to feel like you can recognize and respond to people with mental health or substance use issues. And then finally is being in communication with us about what you're seeing, what you think is needed, and to help us try to know about this and find ways to support you all in this really important work. As I said to you during our prep period, faith leaders in this city and every city, I think, are likely to really be first responders around mental health and substance use issues. You are likely to hear about challenges in families, with people with experiencing personal or challenges, or with their kids or loved ones. And I know that you are an important part of the behavioral health workforce in that sense. And so I really welcome our ongoing work together.
On behalf of our faith leaders, I want to thank you for acknowledging that. And I want to thank you for your incredible presentation today. I think one of the benefits of these programs is that we begin to cultivate relationships with folk like you. And I feel like the conversation is just beginning. And I have to apologize. There were so many questions from our faith leaders and others that we didn't have time to get to. But since this is the beginning of a conversation, I'm sure we will address them in the future. Thank you, Dr. Kunins, for your incredible presentation and giving and generosity of time that you gave to us today, and to Reverend Dr. Butler and to Rita as well. We would ask our attendees to join us on the 18th of November at 8:30, again, Thursday morning, when we will hear from Northern California Field Staff Person Vanessa Greer on the workings of the Citizens Redistricting Commission. This concludes our program for today. Once again, thank you for joining us, and may God bless you.